Welcome back. I would like to introduce our next speaker, Dr. Jennifer Gordon. She is a registered clinical psychologist, associate professor of psychology at the University of Regina. And did I say vagina? No. I said Regina, right? Well, if you're going to say that, say it in this room. When I did my first check-in with my morning team after cancer, I had a little stuffed uterus behind me. I was at home, recovery. I had a little stuffed uterus behind me that someone had given me. And in the control room back at the station, they're like, "Is that a uterus?" I'm like, "Yeah." And they're like, "Do you want that in the shot?" "Yeah," because it's the only uterus I currently own. So yeah, I'm gonna say uterus on TV because that's the part that had cancer. So there's some words that it's okay to say. So Dr. Gordon's work is dedicated to improving the identification, prevention, and treatment of conditions that disproportionately affect women and people assigned female at birth, including premenstrual dysphoric disorder, PMDD. So for another 25 minutes of learning, let's welcome Dr. Jennifer Gordon.
Hi, everyone. It's great to be here. I can skip that. Okay, so just to be completely transparent, just one disclosure to mention. I contributed to the development of a tracking app that incorporates my CBT-based program, but I won't be talking about that today. So first I want to make sure that we're all on the same page in terms of terminology. So when I talk about premenstrual disorders or premenstrual mood disorders, I'm referring to basically two things. So one is PMDD, premenstrual dysphoric disorder, which you may have heard of, very severe PMS. But I also am talking about premenstrual exacerbation of other mental health conditions, so including things like depression and borderline personality disorder. So in my field of research, we're moving towards using this term premenstrual disorders to kind of talk about this family of disorders more broadly than just talking about PMDD specifically. So the treatment of premenstrual disorders in North America is abysmal. So PMDs are under-recognized and under-diagnosed. The average diagnostic delay is as high as 20 years. And you can see the quote there on the slide. This is something we hear again and again, that people have tried a million different medications, have been diagnosed with many different things until they finally realize what it is. So I would argue that it's very important to identify premenstrual disorders early and treat them appropriately. There's research out there showing that people who have a premenstrual disorder are more likely to be unemployed, have to take sick leave because of their condition, get divorced, and are 2 times more likely to die by suicide. So it's more than just PMS. It really requires identification and treatment. So PMDD, I'm going to start with PMDD, then I'll talk about premenstrual exacerbation of other mental health conditions. So it's characterized by severe mood symptoms in the 1 to 2 weeks before menstruation. So it affects 5 to 6% of people who experience a menstrual cycle. But there is an additional approximately 10% of people who have sub-threshold but clinically meaningful symptoms. So they might be noticeable and bothersome. They may require treatment, but just not quite meeting the very, very strict criteria that we have in place for PMDD. PMDD was officially recognized in 2012, so that's when it was integrated into the DSM. So the Diagnostic and Statistical Manual of Mental Disorders is sort of the Bible of psychiatrists and other mental health care professionals. It lists all of the sort of recognized mental illnesses that exist. And many people would argue that this was a huge win for people who have premenstrual disorders because it meant that it was validated and legitimized. And that decision to include it in the DSM was really based on a body of very rigorous research showing that there is a biological basis to this condition. It isn't just made up or based on cultural, or societal beliefs about menstruation. So let me run through quickly the diagnostic criteria for PMDD. So in most menstrual cycles, you need to have 5 or more symptoms that appear before a period. They improve shortly after it starts, and then they disappear entirely in the week that follows. So it shows, you see a very clear sort of on-off pattern. Now, the core symptoms of PMDD include depressed mood swings, anxiety and anger and irritability. Secondary symptoms are decreased interest, difficulty concentrating, difficulties with energy or appetite or sleep, feeling overwhelmed, and then other physical symptoms. So at least one of the 5 symptoms needs to come from that list of core symptoms, and the remaining 4 can come from either list. And then in the DSM, it does, in an ideal world, those symptoms would be confirmed through prospective daily ratings. So it turns out we're quite poor historians. We aren't great at recalling when our mental health symptoms occurred or when there was an absence of those symptoms. So it is important that those symptoms be tracked daily, and that we really confirm that overall pattern, that you're asymptomatic, you don't have symptoms for part of the cycle, and that they do come on in the premenstrual phase. So, okay, I'm just going to skip that for a second. So in terms of the prevalence of PMDD symptoms, so we see here that anger and irritability is the most commonly reported symptom of PMDD. So is that 76% of people report moderate to severe levels. Anxiety is also extremely common. So although you can see depressive mood for sure, often that anger and irritability causing difficulties with their relationships, often causing arguments with romantic partners, or making it difficult to parent, for example. Those tend to be the most prominent symptoms of PMDD. Now, I will take a minute to talk about premenstrual exacerbation of other mental health conditions. So more and more research is showing that almost every mental health condition that we know of can be exacerbated in the premenstrual phase. So not for everyone, but there is a subset of people. So in major depression, for example, there was one study finding that 60% of people experiencing a major depressive episode showed exacerbation of at least one symptom in the premenstrual phase. So that's, definitely more, I think, than most mental health care professionals would expect. Now, there's a large body of research showing that individuals with premenstrual disorders do not have abnormal hormone levels. So that means that there actually is no blood test to confirm whether you have PMDD or a premenstrual disorder, because your hormone levels look exactly the same as someone who doesn't have PMDD. Instead, it's thought that premenstrual disorders are an abnormal response to normal hormonal changes. So the menstrual cycle looks exactly the same, but at the level of the brain, there's an increased sensitivity that results in psychological symptoms that you don't otherwise see. So I'm going to take a minute to talk about the menstrual cycle. So the textbook menstrual cycle is 28 days long. So it starts with the first day of menstrual bleeding, so the first day of bright red blood. And I say the textbook menstrual cycle is 28 days long. We know that there are individual differences in how long the cycle is, so it's perfectly normal to have 25-day or 30-day cycle. There are 2 main phases. So they are separated by ovulation. So you can see their ovulation in the middle. The first half of the cycle is called the follicular phase, and the second half of the cycle is the luteal phase. So there are 2 major hormones that change across the menstrual cycle, and I want to talk about those. So first is estradiol. So estradiol is that not the hatched line, but this line that's highlighted that goes up in the late follicular phase. So at the beginning of the follicular phase, estradiol levels are low. And as you advance in the follicular phase, levels rise and rise and rise until they reach peak levels right before ovulation. those high levels cause symptoms such as like high libido. You might notice that your libido is highest right before ovulation. Increased cervical mucus, so you might notice more mucus coming or in your underwear. Then after ovulation, so that's the release of an egg, there's a bit of a dip in estradiol, and then levels are kind of medium-high until the end of the cycle when those levels drop. Now, progesterone follows a bit of a different trajectory, so you can see that throughout the follicular phase, so that's the hatched line, progesterone levels are low and they only rise after ovulation. So progesterone is high during the luteal phase, that premenstrual phase, and then towards menstruation, they drop. So that drop in both hormones triggers the next menstrual period. That's why you start bleeding. So in terms of how PMD symptoms map onto the menstrual cycle, they primarily occur, so PMDD symptoms will occur in this luteal phase, so the blue here. About 25% of people will experience symptoms throughout almost the entire luteal phase. So that's like half the cycle. Almost 2 full weeks of primarily anger and irritability tends to be the symptom that lasts the longest. The rest of, the other 75% of people with PMDD will experience symptoms primarily in that week leading up to menstruation. And then we're starting to realize, so historically we've thought, okay, do you meet criteria for PMDD? Yes or no. More and more we're realizing that it's a little bit more complicated than that we're thinking about hormone sensitivity on a spectrum from very, very sensitive to those hormonal fluctuations. It can trigger, suicidality and all those bad things that I talked about early in my talk. You can be completely insensitive, and a large majority of people, hormonal fluctuations across the menstrual cycle have zero impact on their mood, and that's important to recognize. But there's also like a huge range of profiles in between. You can have, 3 symptoms that are quite bothersome in the premenstrual phase, or you can have, a little bit of anger and irritability that's maybe noticeable, but not necessarily, requiring treatment. So there's really a huge range. And so I believe that if you suspect that you have PMS or a premenstrual disorder, full-blown, it is definitely worth going through the process of daily symptom tracking. So because we know that each individual shows a different pattern, so there are different hormonal changes that occur in the menstrual cycle, maybe I'll go back to it for a second. So there's the rise in progesterone after ovulation. There's the drop in hormones at the end of the luteal phase. And we're realizing that those different hormonal triggers can, number one, be problematic for different people. So some people are particularly sensitive to that rise in progesterone in the luteal phase. And that is linked primarily with anger and irritability. That drop in hormones leading up to menstruation is problematic in potentially other people, and that is more linked to depressive mood. So we're realizing that there are all kinds of different profiles that don't fit perfectly in the pattern that we expect in PMDD. So you as an individual might find that your symptoms really come on right after ovulation, and that suggests that you're sensitive to progesterone versus towards the end of, as you're approaching menstruation. And some people actually have their worst symptoms in the first few days of menstruation. That goes against our initial understanding of PMDD. That's kind of against the rules of the DSM, but in fact, we're realizing that that's because of that sensitivity to hormone withdrawal. So, okay, back to daily symptom ratings. So, I believe that because we're realizing that there are such huge individual differences in those symptom patterns across the cycle, it can be very empowering to track your symptoms daily and see the overall pattern for you, right? What do you consistently show? Are there particular days that you're most prone to irritability or most prone to depressive mood? So it can help you with anticipation. So for people who experience severe premenstrual symptoms, you can actually pull out your calendar and calculate kind of when am I going to experience this again, and you can kind of plan ahead. And it can help with diagnosis, of course. So if you are seeking medication or diagnosis from a healthcare provider, you can kind of bring your daily symptom tracking sheet to your healthcare provider to show them. So I'll talk about a few symptom tracking tools. Of course, there's lots out there, Flow and Clue, as was discussed before lunch. Here are a few that it's not, data privacy and security is not really an issue. So one is from researchers at McMaster University, the Mac PMSS. So that comes as an Apple app. Unfortunately, I don't have an Android one, but also paper and pencil. So you can just Google it and download it today and print it off. There is also the DRSP, so the Daily Record of Severity of Problems. This is a tool that I'm most familiar with. It's what researchers typically use. The symptoms map on perfectly to the DSM criteria, so that's nice. And yes, again, it's freely available as a PDF online. Actually, I'll give you a direct link at the end. So this is what it looks like. What I really like is that it creates a nice little graph for you. So each day, starting on the first day of menstrual bleeding, you start tracking your symptoms. So item 1 is about depressive mood. So you rate your symptoms from 1 to 6, where 1 is not at all present, to 6, which is extreme. So these are just fake data points, but what someone with PMDD might look like. Relatively low symptoms throughout the follicular phase, and then we start to see symptoms increase and then really reach their peak in the week leading up to menstruation. So what you want to do, and what us researchers do to figure out if you kind of technically meet criteria for PMDD, is to compare your average score in that week leading up to menstruation and compare it to days 4 to 10. So 4 to 10 is just kind of known as this stage where everyone seems to people who are very hormone sensitive have their best week. So I'll say that, but again, recognizing that there are lots of different profiles that you can see. So we're realizing that some people actually experience a flare in the days leading up to ovulation. I've heard people say, it's almost like a mini PMDD episode. And that would be because of that rise in estradiol. So although we technically compare this phase to that phase, you kind of can also eyeball your own symptom pattern and see what are the days that I'm most prone to each of these different symptoms, and it can help you plan ahead. So in terms of what treatment options do we have available if you do have a premenstrual disorder or very severe premenstrural symptoms? Sorry, I'm gonna. So one is selective serotonin reuptake inhibitor antidepressants. So that is a first-line treatment. One important difference between using an SSRI for major depression versus for a premenstrual disorder is that actually it acts quite quickly. So you may know that in major depression, if you have depression, you're given an SSRI, you're told to expect that it'll take about 6 weeks before you see a benefit. That is actually not the case with premenstrual disorders. It seems to be SSRIs act through some other mechanism. We don't actually know which one. We cannot figure it out, but it's something different because it acts within 24 hours. You can see a benefit. So for that reason, you can actually take an SSRI either continuously, or you can take it only during the luteal phase or with symptom onset. So just when you start to feel those symptoms come on, you can take it and you're likely gonna start feeling better tomorrow. So, and that can be beneficial if you're worried about side effects, like sexual side effects, for example. I just said that. Okay, so now drospirenone-containing oral contraceptives is another option. So one very important, different oral contraceptives have different progestins. So the synthetic progesterone is different from kind of brand name to brand name. So drospirenone is a progestin that has the best psychiatric profile for people who are hormone sensitive. So that's why the bulk of the research showing that oral contraceptives can help people with PMDD have been done in oral contraceptives containing drospirenone, like Yaz. Yes, taking an oral contraceptive with a traditional 7-day pill-free window, typically you take kind of 3 weeks of pills and then you have a sugar pill or just no pill for 1 full week, that actually is not effective for PMDD. You need to have a shorter pill-free window, so 4 days max, or you take it continuously. And it's thought that the 7-day pill-free window creates too much hormonal fluctuation. So I often see people who have PMDD who have been put on oral contraceptives for their PMDD, but they have that traditional 7-day window, and that's not going to be any more effective than placebo. So, psychotherapy for premenstrual disorders. Cognitive behavior therapy has been shown to be effective for PMDD and premenstrual exacerbation of other mental health conditions. It is more effective than waitlist, and it's actually equal to medication in head-to-head trials. So that doesn't mean that it isn't related to hormones. I mean, with depression as well, there's always going to be a biological component, as well as sort of how do you respond to that propensity to react in a certain way. And so CBT is all about kind of that reaction. So just to give you a better idea of kind of what would therapy for premenstrual disorders kind of look like. So number one is using that daily symptom tracking tool that I talked about. So I think that's very empowering to know just awareness, even if you don't do anything more than that, just to be able to anticipate those symptoms. And then if you're on a day where you're going to be very prone to anger and irritability, it can help you sort of interpret the situation, right? Like, I'm extremely angry at my partner right now. Is it possible that this is maybe influencing me at the moment? And kind of helps you to have some perspective. So using the daily symptom ratings to kind of plan ahead and plan day by day, using strategies to avoid escalation of irritability. So avoiding triggers. Are there certain things, maybe it's taking the kids to school in the morning is quite challenging just on its own. And then if you are in a phase where you're very prone to irritability, the chances that you're going to kind of lose control and lash out on your kids is very high. So maybe you swap with your partner, for example, or you get a loved one or a babysitter to help. So trying to be really considering what are those triggers that are most likely going to set you off. In very extreme cases where there's a lot of fighting with a romantic partner during this phase, you can even completely avoid each other that evening. Like, if you're very prone to anger and irritability and you just need time alone, then I think there's nothing wrong with planning for that. Just like if you're both on the same page, you both have an understanding, and I do really recommend, if you have a romantic partner and you do have premenstrual symptoms, to talk to your partner about it, that this is not a rejection of you. Let's just think, how can we avoid having this fight kind of every month, Activity scheduling to boost mood. So that's where, if you're prone to depressive mood, it's that's really classic sort of CBT for depression, is planning these little activities that bring a little boost in mood. Now, if suicidality is a problem, SuicideSafetyPlan.com has amazing resources, all free, these little videos on how to create a safety plan. So it's all about kind of planning ahead and helping that person become, keep themselves safe when they're starting to have those thoughts. So that is a great resource. And then integrating distress tolerance skills may also be helpful. So you might have heard of things like grounding techniques. You can Google that, or mindfulness strategies, things that will help you, in the heat of the moment, sort of avoid doing something that you regret, saying that nasty thing, or maybe smacking your child. It's things like running your hands under very cold water, locking yourself in the bathroom and doing that, or sucking on a mint candy and doing some mindfulness exercises. So these are the kinds of things that you would work with a therapist in, kind of planning ahead, thinking what works for you. Not the same strategies are going to work for everybody. For some people, it's very vigorous exercise, for example, that really helps them on those days when they feel really agitated and like they're kind of going to lose it. I'll very briefly mention that in very severe treatment-resistant premenstrual disorders, so they've tried all the things and they still are, for example, suicidal every month, we would turn to injections that trigger chemical menopause. So you get an injection every month and it eliminates that production of estradiol and progesterone. Or in extreme cases, surgical removal of the ovaries. So, that you have to have had tried SSRIs and oral contraceptives and therapy and all of that stuff, but these are options if none of those work. So what if you suspect that you have a premenstrual disorder, or maybe you have a daughter or a granddaughter or a friend? Number one, I would go to iapmd.org and go to the resources tab. So I'm the chair of their clinical advisory board. So they have tons of patient-facing materials that are vetted by experts and researchers to make sure that it's all valid. And they have that DRSP tool that was directly from there, where it creates the little graph. So you can download that, print it off, and start tracking. And seek a healthcare provider, ideally armed with evidence. So you've completed your daily symptom tracking for 2 months. You see there's a very clear pattern. You see your healthcare provider and talk about treatment options. So family physician, nurse practitioner, gynecologist, clinical psychologist. These are all options. Of course, not all healthcare providers are equally knowledgeable about premenstrual disorders. So that's partly why IAPMD is so great, that you as a patient can go there and get evidence-based information and come armed with that information and have thought about kind of what do you want. Do you want to try SSRIs? Do you prefer to seek psychotherapy? And then so that's IAPMD, a QR code there, but you can also just go to iapmd.org and peruse that website. And that is it. Oh, one thing I will say. This whole process gets worse in the menopause transition. So the hormonal fluctuations that I showed you, actually starting in your 40s, will start to become more extreme. We start to see higher highs in estradiol and lower lows as well. So that does partly explain why we see an increase in mental health symptoms in the menopause transition. So I didn't have time to talk about that here today, but I am on the panel after the video that we're going to be watching later. So happy to answer questions about sort of how that plays out later on.
Fantastic. All right, Dr. Gordon, come on over. I like the way you just snuck that little thing in at the end, by the way. Times 1,000 for menopause. So, women are often told these things it's just part of it, you just need to cope. What I'm hearing from you is, actually, no. We have evidence and we have a treatment protocol and a treatment plan, but your best bet in order to get cooperation from your local family doctor, from your GP, is going to be that evidence, that you show up with the evidence and some knowledge.
Right. Yeah.
Okay?
Yeah.
That tells us what we need to do. All right, let's go with questions. Start over here. Oh, I think right there.
Thank you so much for the talk. You mentioned SSRI and OCP as part of the treatment. Do we know much about if IUDs have any effects on PMDD?
Mm-hmm. Yes, we do. They are not effective. So the IUD will not prevent ovulation. So particularly if you're sensitive to that rise in progesterone, it will not prevent that from happening. So no, that's a common misconception. I think a lot of people are put on an IUD as a treatment for PMDD, but so some people are in fact quite sensitive to progestins generally. So some people never do well on anything but drospirenone. And so they might find that they go on an IUD to treat their PMDD, and then they just have PMDD symptoms like all the time, and then it has to be taken out. So no, there's no evidence that it's not a good treatment option.
Good question, though, because we've heard that. Other questions? Somebody over here? Just stick your hand up. There, let's go right here.
So I see a kinesiologist, and I noticed in my luteal phase I lift less. We're just wondering, is that something to do with hormone fluctuation? And I also tend to get like acne in that period. Is it from the rise in progesterone, or like kind of the drop in estrogen, or is it both of them in the tail end?
Right. In terms of, so I'm not exactly my area of research, but I have heard that actually there has been really recent research showing that there are menstrual cycle effects on exercise capacity. I thought it was just a myth for the longest time, but I have been told by colleagues who do that work that in recent years there's kind of more evidence than you would expect. I don't know all the details, but apparently your menstrual cycle can affect sort of how much you can lift and your stamina. And of course, with everything, it's going to be, some people are more sensitive to hormonal changes across the cycle, and that's true of like any part of the body. So probably some people may not notice anything at all in terms of their exercise capacity, and then some people may notice it more, and that just fits with what we know about how there are huge individual differences in the impact of hormones. In terms of acne, I can't tell you I know exactly the answer to that. There are also changes across the cycle in testosterone. So in leading up to ovulation, there's a rise in testosterone there, so that can also play a role.
Where does the chocolate fit in?
Yeah, so I mean, food cravings is also a symptom of PMS and quite common. That is, yeah, I mean, definitely just part of it.
I heard yes. Yeah. Right over here.
Thank you so much for that detailed information. Menopause is one of the reasons why I came here today, and I'm happy, I'm glad I came. So my questions is 3 in 1. The first thing is that when you are about to see your period and then you ovulate, after ovulation is period, right? So when you don't see your period, where does the egg go to? Because my understanding is when the period is coming, you ovulate, and the next thing is the blood, right? So when you're already experiencing like premenopause and you don't see ovulation, you don't see the blood coming after ovulation, what's happening? Secondly, my question is, does premenopause, does it reduce the libido for sex? And thirdly, with all the speakers I've spoken earlier in the morning, talked about don't listen to what they're saying on Instagram, on all the social media. There's a lot of information and too much, actually. So the third question is, I've seen it on Instagram so many times advertised about this, not pills, but this gummies you could eat that will help lubricate that place.
Yeah, those are weed.
Are they... So
that's going to do a lot.
All this texting and with menopause, a lot of information for me to take in. So please, I just need more clarity on that. Thank you so much.
Sure.
How about we can take on one of those? Okay. Do you have an easy answer for?
Well, the first one.
Okay.
Yeah. So it is normal to have the occasional anovulatory cycle. So meaning an egg is not released, and you don't end up getting a period when you would expect that you would. So the occasional anovulatory cycle is normal in a reproductive age female. If your periods are very irregular, though, and that happens quite often, that you don't, it's months before you have a period, that is worth getting checked out and going to see your healthcare provider. You may have a condition such as polycystic ovary syndrome, which should be treated. Yeah. So the occasional off period is normal, but if it's more than that and you're not in that perimenopausal stage, then it is worth investigating further. The sexual stuff, I think we'll talk about also after the documentary. There are going to be some experts here. So
yeah, Dr. Premji, like we're going to all go like this when she walks into the room, because and we're going to bring that up because that's an important point that you brought up. So thanks for that. I think we got time for one more. Right here.
I don't know if you're pointing at me or not, but I'm going to start speaking anyway. I'm a psychologist.
Where are you? Where are we?
Up here.
Oh, hi. Okay.
Hi.
Sorry. We'll come to you next here. Let's go up here.
I'm a psychologist working in a community clinic, and I'm certainly seeing more and more of my female clients coming in, considering PMDD, exploring that. And I'm thinking a lot about these clients who have had prior mental health diagnoses, especially things like borderline personality disorder. And then they're having a harder time, I think, getting the PMDD to be taken seriously, especially with their medical doctors. Mm-hmm. Any recommendations on how I help them to advocate for themselves, given their histories, given this new information, given what we're seeing?
Mm-hmm. Can I just say, before she answers, how wonderful to see someone here in the audience saying, I'm actually here so that I can learn to help those who I am helping. And how can I help them in a more robust way? So thank you for doing that. That's fantastic.
So my answer would be symptom tracking is really going to help a lot in, sort of disentangling. I mean, it is possible to have comorbid, disorders. You can, in theory, have a borderline personality disorder and PMDD, but it is true that many people have been misdiagnosed, right, as having borderline personality disorder, but in fact it is PMDD. It just hasn't been tracked carefully. So I think the tracking and showing that it clearly is a cyclical pattern would help to address that. But it is complicated because, so borderline personality disorder, it can also be exacerbated premenstrually. But it doesn't mean that it shouldn't be treated, in a lot of the same ways. But that symptom tracking, I think, and showing, it's on paper, you're not just recalling events in the past, it's like right there as evidence, so.
Yeah, doctors really prefer to have that on paper, don't they, rather than, well, I was sitting, in the bath and whatever. Okay, well, let's go one more. We've got you right here.
Thank you so much, doctor. I have a question regarding, so I had taken OCPs for PCOS, but OCPs have horrible side effects. And so there is this pro-meno wild yam cream that's marketed
on TikTok?
And Instagram. Yeah, so...
Doesn't give it any more credibility.
Yeah. But, the OCPs have just really bad side effects, and it's not just me, it's just everybody that, I had spoken to. So what are your thoughts on other treatments?
Are there options when you're down that road? Are there options for if one sort of brand doesn't agree with you? Is there a different brand?
Yeah. So I will say that definitely, and it's very individual. Some people respond well to one oral contraceptive and have terrible mood, for example, on another oral contraceptive. So I think it's important to take that seriously. I think most healthcare providers are aware of that you can do well on one and not the other, because as I mentioned, the progestin is different from medication to medication. Drospirenone is anti-androgenic, so it would kind of help with PCOS symptoms as well, and has the best psychiatric profile. I'm not sure what side effects you're necessarily referring to, but it's worth trying a few different ones before dropping it all together.
Is there info on that website that might be helpful?
Yep.
For someone looking for something like this?
Yes, absolutely. Okay. There's also healthcare provider-facing materials as well. There's
we don't know what healthcare provider-facing is.
Oh, sorry. So resources that you can print off and give to your healthcare provider. And so lots of information about different oral contraceptives that are effective and not effective and all of that stuff. So
that might be good for you because then you're going in with that evidence. right? Here, and that's more likely that you're going to be taken seriously. That was an excellent question. I think we have to wrap up with Dr. Gordon. Thank you so much. Clearly, we could be here for another hour listening to you. So thank you for coming.